Clinical Assessment and Planning Nursing Care, Session 11, Neurological Observations. Assessment is of prime importance in the care of a client with a neurological disorder. You must recognise changes that indicate a change in condition, as changes can occur rapidly and dramatically or developed over a period of days or weeks. Neurological observations include checking the level of consciousness, the pupils, motor function, sensory function, and the vital signs. The skull is a hard structure and there is no free space to accommodate expanding lesions such as a blood clot, tumour or edema. Therefore, any increase in the volume of one compartment leads to a reduction in another compartment, leading to an increase in pressure in the skull. And this will result in compression of blood vessels and compromised flow. Causes of increased intracranial pressure include hematoma, cerebral edema, obstructive venous return, tumour and hydrocephalus. The Greek term hydrocephalus is derived from the words hydro meaning water and cephalus meaning head. As the name implies, it is a condition in which the primary characteristics is excessive accumulation of cerebrospinal fluid or CSF in the brain, a clear fluid that surrounds the brain and spinal cord. The excessive accumulation of CSF results in an abnormal widening of the ventricles in the brain, and this widening creates potentially harmful pressure on the tissues of the brain. Level of consciousness, most important factor in neurological assessment, providing valid information about changes in neurological status. Changes can occur slowly or rapidly. A rapidity of change is indicative of the severity of the neurological problem. So the faster the decline, the worse the problem. It can be evaluated by providing stimuli, sound and pain, and observing the response of the client. Speaking is the most common method of applying an auditory stimulus, while painful stimuli is used for clients with a decreased level of consciousness. When spoken to, a fully conscious client should respond with an appropriate verbal response. A client with a decreased level of consciousness may respond in a puzzled way or may not respond at all. Painful tactile stimuli can be provided by exerting firm digital pressure on the nail beds or a sternal rub. Response to painful stimuli can be classified into purposeful, which is when a client winces or pushes the assessor away or withdraws the affected body part. Non-purposeful, the client may move the body part only slightly or when the application of stimuli causes an extensor response, which is a contraction of the muscles only. Or unresponsive, when they show no sign of reacting to a painful stimuli at all. The GCS or Glasgow Coma Scale uses objective observable characteristics and provides a scale by which to measure the level of consciousness and response. The scale is used for assessment of eye-opening, best verbal response and best motor response. It was originally designed to assess the level of consciousness in people with head injuries, but is now used for any decrease in conscious state, such as overdose, which can be either self-initiated or nurse-initiated or post-anaesthetics. It's accurate and effective means of evaluating levels of consciousness. A score of 15 means that the client is fully alert and well orientated to person. A score of 7 or less indicates coma, and the lowest possible score of 3 is indicative of a deep coma. Eye opening. Assessing eye opening provides an indication of the client's arousal ability. Determine if the client responds to speech, so you can use a loud voice, or to touch. If the client does not respond, apply pressure to the finger beds or sternal rub to determine if there is a response to painful stimuli. This assessment determines the appropriateness of the client's speech. In assessing the client's best verbal response, consider the client's preferred language, any diagnosed medical problems that may influence the client's ability to respond, such as deafness, previous stroke, and level of confusion prior to the fall, and determine if there are any changes to the client's pre-fall condition. Assess the client's response and record orientated. Can they respond appropriately to person, place and time? Confused. They can talk but is not orientated. Inappropriate words. They speak only a few words, usually only in response to physical or painful stimuli. Or incomprehensible sounds, so unintelligible sounds such as moans or groans. Or there's nothing, so there's no response after prolonged stimulation. Use simple commands to determine if the client has the awareness ability to respond by movement. If the client does not respond to verbal commands such as squeeze my hands or open your eyes, check the client's best motor response to painful stimuli by pressing the client's finger beds or sternal rub. In assessing the client's best motor response, consider the client's usual level of comprehension, ability to move his or her body, and any existing medical diagnoses that may contribute to the client's ability to move. The pons, the quick facts, the location, the area of the hindbrain that sits directly above the medulla. Its function is to connect upper and lower parts of the brain. So the pons serves as a message station between several areas of the brain. It helps relay messages from the cortex and the cerebellum. Without the pons, the brain would not be able to function because messages would not be able to be transmitted or passed along. Decerebrate rigidity is a posture found in those with lesions of the upper part of the brainstem or severe bilateral lesions of the cerebrum. The patient lies in rigid extension with the arms internally rotated at the shoulders, elbows, knees and hips, extended, and fingers, ankles and toes flexed. The jaw may be clenched with the neck hyperextended. Motor response. So, does the client obey command? Localizes pain. They move their limb away from painful stimuli in a purposeful way or attempt to push painful stimulus away. Flexion to pain. They respond to painful stimuli by bending their arms up and not localizing pain. An extension to pain. They respond to painful stimuli by straightening their arms but does not localize the pain. Assessment of pupils and response to light can provide an indication as to the presence and extent of head injury as a result of a fall or trauma. Information about CNS function or dysfunction. The findings in one pupil are compared to findings in the other pupil, and you need to document the differences if there are any. Pupils are assessed for their size, shape and reaction to light. Normally pupils are equal in size, round, and they constrict briskly when a light is shone into the eye. Abnormal responses of a pupil to light may be described as sluggish, non-reactive or fixed. Any change in pupil size, shape or reaction is indicative of an intracranial change or increase in intracranial pressure. Sluggish or suddenly dilated unequal pupils are an indication that edema or hematoma is worsening and that the oculomotor cranial nerve is being compressed through the foramen magnum. Assessment of the lower limbs can give an indication as to the presence and extent of head injury as a result of trauma. It denotes improvement, stabilization or deterioration in the client's condition. It usually focuses on the arms and legs, and in the conscious client, observe motor responses to directions, such as asking the client to squeeze your hands. If the client does not respond to your request, assess limb movement in response to pain. Observe the type of movement the client can perform and compare the strength of limbs on both sides of the body. In assessing the client's limb movements and strength, consider the resident's previous condition and any medical diagnoses that may preclude normal limb movement, and consider whether the client has sustained injuries to the limbs during the fall or injury that may preclude normal movement, such as fractures. Upper and lower limbs should be assessed separately. Ask the patient to hold their arms out in front of them and observe for signs of weakness. Assess the legs by asking the client to push or pull feet towards the assessor. Muscle tone is the true ability of the muscle to respond to stretch and the amount of resistance to movement. Record. Does the client have normal power, so movements are within the client's normal power strength? Mild weakness. They cannot fully lift their limbs against gravity and struggle to move against resistance. Severe weakness. They can move limbs laterally but cannot move against gravity or resistance. Spastic flexion. The arms slowly bend at elbow and are stiff. Or extension. The limbs straighten. Assessment of the vital signs provide data concerning vital functions of the body. The client's temperature, pulse, respirations and blood pressure are monitored and documented at a frequency that depends on their condition. Data from the neurological assessment is documented according to the healthcare institution's policies and procedures. There are various reasons for taking a client's TPR. It's important to ensure you have gained the client's consent prior to taking vital signs. A series of measurements is more useful than a one-off measurement as it enables a trend to be recorded. A trend is useful to help identify and monitor potential problems, and whenever possible compare different vital sign trends, as these can also provide additional information. Reasons for taking vital signs: on admission to provide a baseline which can be compared with subsequent measurements, thereby providing objective data and trends. To monitor effects of any treatment or medication. To give an indication of the patient's general condition and help to identify changes or deterioration. The client's conditions may change rapidly or slowly over time. Remember, a baseline measurement may not always be the person's normal measurement.